So breath testing and Brexit, two things that are rather emotive. And as a physiologist, we almost feel like a civil servant at the moment, because on the one hand, we've got patients who've got a lot of symptoms that might be due to bacterial overgrowth. On the other hand, we've got doctors who don't believe in bacterial overgrowth, and we're in the middle trying to sort it all out and to see what the mess is.
Can you help find your presentation?
Yeah.
What's the date? That one, is it?
Yeah, the one that says AGIP. So what we've tried to do, as clinical scientists and as physiologists, then we try and be as agnostic as possible and just like use data and evidence to support what we do. So what we've done over the past 18 months or so is look at the data about breath testing. Everyone was doing it in a different way, and try and come up with some kind of consensus so that we can all actually do it in the same way. And even though we know it's not a perfect test, at least then we can compare results, just like we've done with the Chicago for manometry, and then actually look at outcomes data, because ultimately outcomes data is what is going to tell us how useful these tests are. But as physiologists, then we try and be as apolitical as possible and just do the best quality test that we can. So, just declarations here. As Warren said, I work for the Functional Gut Clinic. We're a private clinic, and we also, for functional gut diagnostics, and we actually sell breath test kits, so that's my kind of declarations. Now, I see hydrogen and methane breath testing as a provocation test for the bowel. Back in the day, when we used to do things like the Bernstein test and put acid into people with reflux disease and try and provoke symptoms, then it wasn't always super useful. But I think what we can do with the different carbohydrates we use for breath testing is to try and provoke symptoms and look at a physiological change, and then try and put those things together, treat patients and see if they get better or not. It's just got a pointer on it. Yeah. So this slide just shows us a little bit about digestion and fermentation. What is supposed to happen, as you know, is that we swallow something, it sits in the stomach for a certain amount of time, and then it slowly empties into the small bowel. And if it's a carbohydrate like lactose or fructose, it should get absorbed in the small bowel, and nothing should reach the large bowel. However, if you don't digest carbohydrates properly, then those carbohydrates reach the second stomach, which is the cecum, and here they get fermented by bacteria. And that bacterial fermentation can act a little bit like a laxative, so it can make you feel bloated, it can make you feel gassy, it creates an osmotic gradient, and can cause symptoms like diarrhea and so forth. And what we're testing with breath, hydrogen and methane is this process of digestion and fermentation. So, interestingly, about 10 to 15% of our calorific intake is due to secondary fermentation of stuff that we don't digest normally. So bacteria break down these carbohydrates, and the short chain fatty acids are harvested and absorbed, and that gives us a certain amount of our calorific intake. And this predominantly occurs in the cecum, which is depicted here. But in some people, if the bacteria is actually up in the small bowel, then these processes that should occur in the colon occur in the small bowel. And the small bowel is small, and it's quite sensitive, and it doesn't like it, and it can cause a lot of symptoms. Now, if the fermentation that occurs in the colon is either fermentation of stuff that we should have digested, so like lactose and fructose, then we get excessive fermentation that causes bloating. So this is a problem of absorption. But also, a lot of research now is around the microbiome, and if the bacteria that are resident in the colon are different to normal, then the fermentation that occurs can be excessive, and it's a malfermentation problem caused by a microbiome change that is the issue. And I think that's where we are now as physiologists, is trying to figure out where the problem is. Is the problem because the bacteria is in the wrong place? Is it because we're not absorbing things properly? Or is it because the bacteria in the colon is actually abnormal? So what can hydrogen and methane breath testing be used for? Small intestinal bacterial overgrowth is the main thing that we test for. Carbohydrate malabsorption, and those carbohydrates can be lactose, fructose, sucrose, anything that can be kind of ingested, but the main ones that we do are for lactose malabsorption. We also, in our clinic, look at colonic fermentation. So what happens in the second half of the study? We know that normal people will ferment things like lactulose to a certain level, but when the lactulose reaches the colon, the hydrogen that we measure is 3 times the amount we see normally. Is this a problem with colonic fermentation? And I think what we see is that hydrogen and methane production can be seen as the functional consequence of the interaction between the microbiota and what we ingest. I think that's really important. Just like Andres has showed that the impedance that we see during manometry is the functional consequence of the manometry, what we're measuring here is the functional consequence of the ingestion of what we eat with microbial populations. So the problem we've had in the past is that the methodology, interpretation and applications vary widely across the UK, and the Americans took a big leap forward in 2017 by developing the North American Consensus document, and that basically sparked us to do the same thing in the UK. So this is in the American Journal of Gastroenterology. I'm just going to go through a few slides, but I think you will be able to download this. So bacterial overgrowth, what is it? So because we've got acid in our stomach, and the acid in our stomach is really quite strong, then it disinfects pretty much everything that we eat. So the amount of bacteria that should be in the duodenum is virtually 0, because it should be a fairly aseptic environment. As you go down the small bowel, then you get a slight increase in the amount of bacteria, up to 10 to the 3 colony-forming units per mil of aspirate. So we get a little bit of bacteria in the distal small bowel, very little in the proximal. But when you jump to the colon, you get 10 to the 11. So that's a huge number, orders of magnitude more bacteria in the colon than you would expect in the small bowel. And I really like this slide because it's a really good depiction of actually how unpleasant small intestinal bacterial overgrowth is. So if you imagine you eat something that's easily digestible, like rice, you break it down, you digest it, it gets absorbed before anything happens, any fermentation. Now, if you eat beans that are poorly digestible, high in fibre, you absorb some of it, but some of it goes into the colon, and guess what? If you eat beans, you fart more. So that's a normal process for everyone. So this fermentation is the normal amount of fermentation. But if you have bacterial overgrowth and the amount of bacteria in your small bowel, is higher than it should be, even easy digestible food starts to get fermented in the small bowel. As I said, the small bowel is not used to this. It's got a hugely rich innervation, sensory nerve endings, it's small, it gets irritated quite easily. So not only do hard to digest foods start to get fermented in the small bowel, but easily digestible foods. So everything you eat makes you feel pretty rotten. And this was just a quote from a paper in 1992 that really struck with me, that bacterial overgrowth probably leads to the putrefactive breakdown of metabolically useful products of protein digestion. And I kind of Googled putrefactive, and it said it's the act or process of putrefying, the anaerobic decomposition of organic matter by bacteria and fungi that result in obnoxiously odorous products rotting the state of being putrefied. Now, that's pretty unpleasant, and if that thing is happening in your small bowel, it's going to make you feel pretty rotten. And when you talk to people with SIBO, they describe it as feeling like they're being poisoned every day. And this is because this putrefaction is actually occurring in a very sensitive region of the bowel, and it's abnormal. So, it is something that has to be considered as a really abnormal process. So what are the causes of SIBO? There are structural abnormalities, there are motor abnormalities like hypomotility, things like pancreatic insufficiency, so you're not producing enough enzymes to break down the food properly, hypochlorhydria, radiotherapy, and one of my areas of interest for research now is the prolonged use of PPIs, which I'll go into a little bit, but also previous gastroenteritis. People travel around the world all the time now and come back with various weird diseases, and that is one of the major causes of SIBO. So just looking at the PPI usage here, this is a study from an Italian group that showed that as you keep taking PPIs from 2 to 6 months, 7 to 12 months and onwards, then the percentage of people that have a positive SIBO test goes up towards 70 to 80%. And we've just had this accepted at DDW. We've shown a similar amount of prevalence of SIBO in people on long-term PPIs. And this is really important, especially with Steve being here in the room as a surgeon and many of the other surgical colleagues, that when a patient comes to your clinic with reflux, they usually have reflux symptoms. But then as they go on long-term PPI usage, then their symptoms seem to change from being predominantly heartburn and regurgitation, which PPIs treat really well. They start to develop increased bloating, flatulence, abdominal pain, up until the point where these become the predominant symptoms. And these patients are described as being refractory to PPIs. Well, the PPIs have done their job. These people don't have reflux anymore. You know, PPIs were designed to take for 1 month, 2 months, whatever. They weren't really designed to be a lifestyle drug or taken for a long time. And what you're doing quite often in these patients is you're turning them from a reflux patient into a IBS patient. And you know, one of the main symptoms that you get from anti-reflux surgery is excessive bloating and stuff. But when you actually question these patients, they have bloating and distension afterwards. So this is one of the things that we're looking at now is how we can get people off their PPIs and see whether these other symptoms can resolve and they don't need to go on to have surgery. So the principles of hydrogen and methane breath testing, they're byproducts of colonic fermentation by the microbiota of undigested food products. We don't produce these gases naturally. The gases are absorbed into the blood and excreted by the lungs, and the gases can be detected in breath samples. Before the test, we do a 24-hour low-fibre, low-residue diet, and we do it a little bit longer in constipated patients because things go through the system a little bit slower. We're going to talk about this a little bit more about the conservative analysis about what the thresholds for SIBO positive and negative are. But usually what we say is that in the second part of the study, anything above 60 parts per million should be considered as excessive colonic fermentation. We also measure symptoms during the test because the physiological outputs that we put married together with the symptoms seem to make that more sensitive. And for SIBO, we either use glucose or lactulose, and then we also look at fructose and lactose. You can use other substrates like mannitol, sorbitol, but the normal ranges for that are not really established. So lactulose, we see it as a provocation test because it goes through everyone. No one can digest lactulose, so everyone should get a response to it, and we should see a peak if they've got a normal microbiota. So first debate is glucose versus lactulose. Glucose is very sensitive in terms of if you get a positive with glucose, it's a really strong signal. The problem is it's very quickly absorbed, so you only really get a signal in the proximal duodenum. So if the bacterial overgrowth is lower than that, you're going to get a false negative response. So glucose is great if it's positive. If it's negative, you should really do lactulose. And for that reason, we tend to do a lactulose study first, and if it's borderline, we'll go back and do a glucose and try and support that positive diagnosis. Lactulose goes through the whole system, so it isn't absorbed in the small bowel, so it will get to the colon, and in the majority of patients, you will see some kind of bacterial activity and gas production, so we get a full study. The problem with lactulose is if it transits too quickly into the colon, then you may get a false positive result. And that's where the debate lies about the sensitivity and specificity of the two things. But using them together and using a bit of common sense, then you can usually overcome these issues. So I'm going to scoot through this quite quickly. The US consensus looked at about 20 questions. And what we've done as AGIP is go through these questions and try and see whether we agree with them or not. We don't have to be led by the US, but the majority of the questions that they put forward, and these slides will be available to you all after the conference, so you can look at them in more detail. I'm just going through the things that we agree with and the things that we don't agree with. The main thing that we struggled with was this cutoff point here of a rise of 20 parts per million at 90 minutes being positive for SIBO. And I'm going to talk about that in a bit more detail here. So this is data that we've done at the Functional Gut Clinic to try and back up our decision making. And it's a retrospective analysis looking at the parameters from the North American consensus and our own experience. So we looked at glucose versus lactulose, effects of dose on SIBO prevalence, effect of time on carbohydrate malabsorption, SIBO testing before carbohydrate malabsorption, and methane prevalence in the referred population. And we also had a quick look at the SIBO cutoff values. So looking at the difference between dose for lactulose and glucose, what we previously used, which was recommended by the companies, was 16 grams of lactulose, and we used 50 grams of glucose. The North American consensus suggested we should use 10 grams of lactulose and 75 grams of glucose. So what effect did that have? If you use 16 grams of lactulose, you will get more positives for SIBO, regardless of what cutoff you use. If you use 75 grams of glucose rather than 50 grams, then you will get more positives for SIBO with that higher dose. And if you look at the symptoms that you generate, you get more symptoms generated with a higher dose of lactulose than you would do with the lower dose. So all of that's kind of intuitive. But with lactulose, the SIBO positive patients with 10 grams of lactulose have more symptoms than the SIBO negative population. But there's no difference with symptoms with glucose because glucose is absorbed quite readily. The conclusion that we came to, and this has been adopted now by our UK guidelines, is that it's better to use a higher dose of glucose, so 75 grams rather than 50 grams, and it's better to use a lower dose of lactulose, so 10 grams. So what you're doing here is reducing the risk of false negatives by increasing the dose here, and reducing the chance of false positives by lowering the dose of lactulose. So that's what we've adopted in our guideline. And this just shows here, you've got less positives with the lower dose of lactulose and you've got more positives with that. So somewhere, the truth lies somewhere in between these two, but I think this is a pragmatic way of testing for SIBO, is to use these doses of these substrates. And we would generally recommend you do lactulose first just to make sure that you're getting a full curve. Carbohydrate malabsorption, then there was a little bit of debate. Do you need to go to 90 minutes, 120 minutes, 3 hours, 4 hours, 6 hours? The consensus in America said to go to 3 hours, and what we did is to show if we compared data between 2 hours and 3 hours, we got about an extra 10% yield in positive data for carbohydrate malabsorption with lactose and fructose. I know Warren's done a little bit of work about this, that maybe possibly extending to 4 hours you might pick up a few more, but I think pragmatically 3 hours seems to be the sweet spot for picking up most of the abnormalities that you want to see. Methane is really important. You know, there are a lot of devices now that are available where you only measure hydrogen. Hydrogen is only one part of the story. So ourselves, Warren and Steve Perring's group have all got very similar data now, looking at our retrospective analysis, that about 18% of all of the patients that are referred for breath testing are methane positive. So, you know, it's quite a big proportion, and that seems to be consistent across centres. The majority of those are SIBO negative, but people with methane is associated with slowing gut transit. So these are people who are more likely to have bloating and constipation. Really importantly, what we found is that patients who are on oral iron supplementation have a big higher prevalence of methane production. And as you know, the oral iron supplementation is associated with GI symptoms in 70% of patients. And iron is one of the key ingredients in methane production. It triggers the bacterial enzymatic pathway of making methane. So if you're doing a breath test, always check whether patients are going to be on oral iron supplementation. And again, this data is going to be presented at DDW soon. So if you're not measuring methane, you're missing the picture in a lot of patients. So just be wary that you know, if you've only got a hydrogen measuring system, then you might need to either upgrade or refer on to a place that has methane possibilities. Predominant bowel habit, here what you can see is that whilst the overall population is about 18%, this is mainly in constipated patients, so the prevalence of methane production in constipated patients is about 30%. And why is it relevant? Actually, if you treat the methane-producing bacteria with antibiotics, you can actually improve clinical outcomes. So here, if you give, this is an American study, neomycin and rifaximin, you get eradication of the methane-producing bacteria, and this translates to a very significant clinical response. So it is an important thing to measure. SIBO cutoffs, this is the contentious thing. You know, as Andres has said previously, you know, engage your brain when you're doing a study. Don't just use the values as blindly. You think about the patient's symptoms, think about the situation, think about you know, the interaction and what the consequences of treating SIBO might be. Ledenchowski has got this conservative measure of 10 parts per million. The North American consensus is 20 parts per million at 90 minutes. And what effect does the cutoff have? We feel that the American values are not sensitive enough earlier on. So if you get a rise of 10 parts per million within that kind of 45 to 90 minute period, the Americans have said that was negative, and we think that's not true, especially if it's associated with symptoms. But it might be too sensitive later on. So if you get a rise of 21 at 90 minutes, then this could quite likely be in the colon. The only way to test this properly will be with outcome studies in the future and with treatment studies. Even that will not be the ultimate question because the treatments will affect the colon as well as the small bowel. But I think it's better to err on the side of caution, and therefore we kind of are somewhere in between. So what we've shown is that 33% of the tests diagnosed negative according to the Ledenchowski parameters will be deemed positive with the North American. But symptom analysis shows that only 8% of those patients had symptoms during that part of the test. So we think that it's basically showing false positives there. About 12% of the results diagnosed positive according to the parameters will be reassigned as a negative result. But in those patients, 20% of those patients had symptoms. So we think that they will be missing it as a positive result. So we're hedging our bets a little bit, and I think common sense has prevailed. But I think a rise of 10 at 60 seems to be the consensus for most of us at the moment. If you get something that's falling in that grey area, then clinical judgment discussion at the MDT will be appropriate. We always look at symptoms during, this is quite contentious. The symptoms for us are really important because just with reflux testing, if you've got a positive symptom association, then it gives you a bit more confidence that what you're measuring has some clinical relevance. So I would say always look at the commonest symptoms like nausea, bloating, pain and cramping, but also other things like, you know, these patients have weird and wonderful symptoms like brain fog and tiredness and fatigue. Just try and map together what you're seeing physiologically with what the patient is feeling. Other factors, are you provoking bowel movements, GI symptoms like belching, borborygmi, reflux, etc. Extra GI symptoms, headache, tiredness, dizziness. Some people get emotional during the breath test. You know, is that relevant? But you know, you are stimulating the autonomic nervous system, so it could be a manifestation. One of the objective things you can measure abdominal girth. The important thing is that you must adhere to a strict low fibre, low fermentable diet at least 24 hours before to make sure baseline gases are below 10 parts per million. So we're nearly done now. One of the symptoms that we found most sensitive for SIBO patients, and this has been confirmed with studies in the States, is nausea. So even though only 20% of the patients referred to us have nausea symptoms, of that population, about 80% of them are positive for SIBO. And as I say, this has been confirmed with scintigraphy studies in the States, so nausea is quite an important factor. And Warren's very kindly sent me these slides about how we get the substrates now. So various hospitals you know, want to try and control the quality of the substrates that you use, and Warren has sourced 75 grams of glucose within the solution called Lactulose that you can get from your pharmacy now. And again, these slides are available to you after the conference, and that's about £3.50 per study, so that's a really convenient way of giving the substrate to your patients. Lactulose is readily available from most pharmacies anyway, so you can measure it out, and sachets are available as well. Slightly more expensive is the lactose solution, but very convenient because lactose is quite difficult to mix up. But Warren has found a place now in Huddersfield. I don't know if you get commission from this, Warren, or not, but, but it's priced at £14.39 here, but the solution is in the bottle, and your hospital pharmacy should recognise that as being GMP quality, and you can just give it to the patient straight away, so really convenient. What we use in conjunction with the bed font system that we have in-house, we also have these postal breath kits where we can do like test tube analysis, so patients can actually do the breath testing at home, and all the constituent parts are in there, and they come with the substrates here, be they fructose, lactose, glucose or lactulose. So in conclusion, The UK is broadly in agreement with the Americans in terms of breath testing. There are a couple of contentious issues. The AGIP position statement has actually now been accepted by the Neurogastro Committee and the BSG, and it's been published in New Wave, so you should have all got a copy of that. And Adam Farmer is very kindly just going to expand on that document and try and publish that in Frontline Gastroenterology. And the importance of that is that we can all now start to do breath testing the same way. We can all then start comparing results, and we can all then decide on whether this is a useful test or not. I think for me, SIBO is a real condition. It's been a really weird 18 months of seeing how polarised people are about SIBO. And I do understand that gastroenterologists are concerned about the injudicious use of antibiotics in IBS patients. But there are non-absorbable antibiotics that are safe to use. And I think we need to do more research in this area to try and prove whether this is going to be a useful treatment going forward. The establishment of the UK Breath Test Consensus Group I think is the next step for us all. So now we've agreed on how to do it all, I think what we're hoping to do is to invite to the AGIP membership people who want to join this group and want to start generating data. And the proposal really is that we're going to invite AGIP and BSG members to join a group and like a subcommittee, if you like, for breath testing. And then we can start to collate data on existing services, identify priority areas for research, and really try and move the science on as we go forward. Thank you very much.
Thank you.